Okay, so spine image is one of the very important. So here I'll be talking a little bit about the X-ray, little bit about CT scan, and mostly of MRI, because in spinal pain, the MRI is the most important, the gold standard to evaluate the pathologies as well as the different painful conditions. So I'll be starting with X-ray first. So what are the things which we can diagnose with X-ray? So these are the things which we can. So spondylitis, spondylosis, spondylolisthesis, spondylolysis, and some other fractures. So I'll be just briefing a little bit about in short about what is the meaning of these terms. And many of these terms are used inappropriately, I should say. Like, nowadays our patients are very smart. Many a time they'll be coming and they'll be telling, "Sir, when you are asking, what is your problem? I'm having spondylitis in my neck, or maybe spondylitis or spondylosis in the back," without knowing the meaning exactly what is the meaning of the spondylosis or spondylitis. So what is the meaning of spondylitis? Spondylitis term is, only spondylitis term is mostly used by the lay people. Basically, spondylitis term is inappropriate. The better term is spondyloarthritis. If you're talking about the inflammatory disease of the spine, then the better term is spondyloarthritis or spondyloarthropathies. So spondyloarthropathies is a big basket of disease where there are a lot of different kinds of inflammatory diseases which primarily affect the spine joint. Spine joint means sacroiliac joint, the facet joint, so other part of the spine. So here in this basket, we are having few diseases. One of them is very important is ankylosing spondylitis. The others are reactive arthritis. Then the psoriatic arthritis. These three are the most common. So in this basket, there are a few other uncommon, the inflammatory conditions of the spine. So all these are inflammatory disease of the spine. They are in total, they are called the spondyloarthropathies. And the contrary to the other kinds of inflammatory joint disease like the rheumatoid arthritis. So rheumatoid arthritis involves the small joints. Which small joints? Normally the proximal interphalangeal joint or metacarpophalangeal joint, the other joints which are primarily involved. Whereas it spares the facet joint, SI joints mostly. And opposite for the spondyloarthropathies. So spondyloarthropathies is also a similar kind of inflammatory disease where the SI joint, facet joint are affected most. Cervical spine are common in both spondyloarthropathies as well as the rheumatoid arthritis, like atlantoaxial joint. So these are the areas which can be involved in both either of that. And large joint, like how many large joints are there in the body? So 5 on either side. So elbow, wrist. Remember, wrist is a small joint. It's not a large joint. So elbow, shoulder, hip, knee, and ankle. The other large joint. So this 5 into 2, so 10 large joints are there. So large joints can be involved both in spondyloarthritis as well as the rheumatoid arthritis. So anyway, so we are talking about the spondylitis. So spondylitis term is basically a lay people term. So better term is your spondyloarthritis. And ankylosing spondylitis is one of them. Then comes your spondylosis. What is the meaning of spondylosis? So, okay, first of all, let me talk about the spondylitis. So spondylitis, particularly the ankylosing spondylitis, can be diagnosed by the X-ray. What are the features? We can see the sacroiliac joint inflammation, sacroilitis. So there are, I'll be coming to this picture later on, as well as we might be bamboo spine is a very late feature. So before that, we can get the squaring of the vertebral body. Vertebral body in the lateral view is not exactly like the square. So there is curve in the anterior margin. But in spondyloarthritis or spondylitis, so that will be looking like a square. and there might be the the other changes, the calcification of the anterior longitudinal ligament. So these are the early changes. So the late changes are bamboo spine. So this can be diagnosed as in X-rays. Spondylosis can also be diagnosed in X-ray. So what are the spondylosis features? Spondylosis means, what is the meaning? What is the definition of spondylosis? Spondylosis is degenerative changes of the spine. So which part of the spine? Any or all part of the spine. So it can be your facet joint, it can be your vertebral body. So there might be osteophytes, there will be degenerative changes. So all these changes will be there in the spondylosis. So on the very common mistake we always do, that whenever you're talking about the causes of the back pain, we must not say the spondylosis is the cause of the back pain. Why? Because spondylosis is a non-specific term. It is not telling which part of the spine. It is not telling whether SI joint is degenerated, whether the disc is degenerated, whether the facet joint is degenerated. So it is not specifically telling where is the pain generated. And that is the reason why the spondylosis should not be talked about, about the cause of the back pain. We should be more specific. Other day we talked about the pain generator. At that time we talked that pain generator should be specific. It has some certain nerve supply, and there are a lot of structures which can be a pain generator in the back pain or in the spine pain as a whole. So spondylosis is not telling which is where is the pain generated. So spondylosis term is it's a degenerative changes, and it should not be talked about the cause of the back pain unless we are having a specific diagnosis of it. Then spondylolisthesis. What is it? So one vertebral body is slipping over the others. So if it is slipping anteriorly, anterior listhesis. If it is slipping posteriorly, it is posterior listhesis. And the listhesis can be because of the two reasons. If you are looking about the facet joint, so that the facet joint structure is such that it prevents listhesis. It locks one vertebral body with another vertebral body. If you are looking about the structures, one vertebral body have the superior articular facet from the below, superior articular process, superior articular facet from below, which is the concave internally, and another coming from above, which is convex outer. So they are fixing, and they prevents the slipping or gliding over the one vertebra of the others. So facet joint, one of the very important function of the facet joint is preventing listhesis. So listhesis is not possible unless either of these two. One is there is a gross degeneration of the facet joint, and ligaments capsule of the facet joint is laxed. That is one. Or second is if there is a pars fracture. Then also there is that means the pars interarticularis, if it is fractured, then also the listhesis is possible. Otherwise, listhesis is not possible. So this fracture of the pars interarticularis is called the spondylolysis. So that is another reason for the spondylolisthesis. So spondylolisthesis can be because of the degenerative changes of the spine, because of the spondylosis, or spondylolisthesis can be because of spondylolysis as well, and some other fractures like vertebral body fracture. So spondylolysis is also a fracture, and other fracture means vertebral body or some other fractures can also be diagnosed by the X-ray. Now let us have some of the example, and before that, this is also very important. Last day also we have discussed in our demonstrations on the mannequin. So in the AP view, what are the structures we see? And you have to always remember that this picture is a 2D picture, and our spine is not a 2D picture. Our spine, like if you are pressing it and making it as a flat, so then it's like a the vertebral body, the lamina, all becoming becoming one. 3D is converted into 2D. So in your brain computer, we have to again calculate back. So here you see. So this is your vertebral body, and here is the lamina. So they are superimposed over with one another. So you have to understand, we have to know the 3D structures nicely, and we have to understand that which structures is superimposed over which structure. So what are the structures you can see? One is your pedicle. Again, this is one of the very important concept, that the pedicle is not a rounded structure itself. Its pedicle is a pillar. So it's like a pillar. But when this pillar, suppose my finger is a pedicle. If I'm seeing by the lateral view, I'll see it is a pillar. But if I see with the AP view, then this pillar becomes a rounded structure. So like an artery. in the pulmonary artery, many times you see that the pulmonary artery, either long structures, if it's the CM beam is falling, longitudinally. But if it comes in line with this artery, it will be showing as a circular. Same here. So this is your, the rounded, because CM beam is coming like that perpendicularly over it. But if the CM beam is coming laterally like this, then you can see this pedicle as a pillar. So this is your pedicle. 1, 2 is your lamina, 3 is your spinous process. Again, if you see the lateral view, spinous process will be broadened. Here it is in the, this is called tunnel vision. Already this has been discussed last class. So transverse process. So all these things you can see. Here is your superior articular process. Here is your inferior articular process. So here is a facet joint, very faintly seen because here is a facet joint, but facet joint cannot be seen nicely in the AP view, and that is why we can't see it nicely. So this is your, the lamina. This is your, the interlaminar black space is the interlaminar space, the 10. And when you are going into the spinal or epidural, we are basically targeting this 10. So this is your AP view. So you need to understand all these structures in the AP view, oblique view, lateral view. I tell this as a very simple example, very simple exercise. So, you must all be practicing it. This is important for also your CRM guided procedures. You download from the internet that the AP view of the lumbosacral spine or oblique view of the lumbosacral spine, and you'll be getting thousands of X-rays. And what you do, you just try to identify each structures. Like here is marked. So try to identify each structures, which will be very good practice for your learning and understanding the X-ray. Because as I told you, the 3D picture is converted to 2D in X-ray. You have to understand that. Now let us go into the lateral view. Lateral view. Again, this is the pillar. This is the pedicle. So when the CM beam was focusing like that, we are seeing as a circular structures. So this is your vertebral body. This is your pedicle. What is transverse process? Transverse process is now here becoming small here because the CM beam is focusing over the transverse process. So it is now in tunnel vision. And this is your superior articular process, superior articular process. This is the inferior articular process. Lamina will be here only. And here is your spinous process, the big spinous process. This is in the lateral view. And if you are going into the, this is also AP view. But, here there is one abnormality. What is that? You see, 1, 2, 3, 4, 5, 6. So there is 6 lumbar vertebrae. So what are the possibilities? One possibility is either 12th rib is absent. So in many situations we don't have 12th rib, or there is a lumbarization. H1 is lumbarized. But here, which is more likely? So more likely is here that 12th rib is absent. Why? Because normally, if you are joining these two iliac crest, it should go along the L4-5 vertebra. That means most likely this is your L5, this is your L4. Then this is L3, this is L2, this is L1. So most likely this is your T12. But finally, you have to remember, it is very difficult to make on a comment whether this is really, your T12 or not. And there we need to count it from the cervical one. So same for the, when you are looking at the MRI. So many times it is difficult to say whether it, because L5 sometimes looks like S1, that is called sacralization. And when S1 looks like L5, that is called lumbarization. So many times the lumbarization or sacralization is difficult to comment unless you are counting from the above from C1. But one thing what you told, the other two, or if you are joining these two lines, then it will go through the L4-5 interspace. So most likely this is your T12, but we have to look for that also. So now look at this picture. So what is the abnormality here? You see, what is this? This is your most likely the S1. This is most likely your L5. You see the iliac crest. So iliac crest normally runs along the L4-5. So this is 5, this is 4, and L5 is 1. You can see this is very dark. So why this is very dark? And this space is also very much reduced. If you are comparing this space versus this space is reduced. So this is your called the vacuum phenomenon. So vacuum phenomenon means there is gas inside, and that's why it's looking black. So what gas? So mostly it's nitrogen gas. So this is one of the very important sign of the disc degeneration. So if you see this vacuum phenomenon, gas shadow inside the disc, so that is called the surest sign of the disc degeneration. So one of the two important signs for the disc degeneration. One is loss of disc height, and another is vacuum phenomenon. Otherwise disc degeneration is very difficult to comment on X-ray. So these are the two important signs on the X-ray with which we can tell that the disc is probably degenerated. And this is your oblique view. So in the oblique view, so this is your the transverse process, and you can see the facet joint so nicely opened up the facet joint. So this is inferior articular process, superior articular process. You can see the pedicle, transverse process. This is the neck of the Scottish dog. You can see the Scottish dog. So this is the front leg, this is the hind leg. So this neck of 4 is called the pars interarticularis. So if there is a fracture, then this is called the spondylolysis. And spondylolysis, I told you, either facet joint degeneration or spondylolysis, these are responsible for your listhesis. So you have to again the interspace. So you go for the the interlaminar epidural. So this is your 8, and so all these structures in the epi, oblique, and lateral view you have to remember. And this is a very important popular questions, in your viva or in your multiple choice question. So it will be marked and you will be asked that which structure is it. So now here you can see the spondylolysis. You see the pars interarticularis. It is best understood by the oblique view. See, this is the oblique view, but this is the lateral view. Lateral view also you can assess, but because of the lateral view, the other side pars interarticularis is superimposed. Sometimes it is difficult to diagnose the fracture. But in the oblique view, we can easily identify that this is the Scottish dog. You can see the Scottish dog, and this is the neck. So neck is, compare the neck here and the neck here. So it is fractured, and this is called spondylolysis. So it is one of the important reason. You see here, there is a spondylolysis. So it's a spondylolisthesis, and that is responsible for the spondylolisthesis. So L5, you can see L5 has moved anteriorly over this one. So this is your spondylolysis producing spondylolisthesis. Now you see, whenever there is spondylolisthesis, why spondylolisthesis is important to us, and when the spondylolisthesis patients need operation, assuming that all of you are pain physicians. So this is one of the very important decision to take, that all spondylolisthesis do not need a fixation plate screw surgeries. So spondylolisthesis, there are 5 grades of spondylolisthesis. So what are those? So you see, this vertebral body is the slipping over it. So if we are making it the percentage, so this is approximately 25%, then 50%, then 75%, then 100%. So this 25, 50, 75, 100. So that means if it is moved more than 25, less than 25, that is your grade 1. So 25 to 50, it is your grade 2 listhesis. 50 to 75, it is your grade 3 listhesis. 75 to 100 is your grade 4 listhesis. And if it is completely, this is not in touch, this part is out of here. So then it is your the grade 5. So normally grade 5 spondylolisthesis is not possible unless there is a fracture. So the grade posterior ligamentous complex. I'm coming to that part just now. So only then it is possible. Otherwise, grade 5 listhesis is not possible. Grade 5, grade 1, grade 2 is very common. So the question is, why and what kind of symptoms a spondylolisthesis patient can do? So if there is a spondylolisthesis, what will happen? So there is facet joint. So if one vertebral body is moving over the other, what will happen? This facet joint will be overloaded. So the commonest reason for presentation of a spondylolisthesis patient to a doctor is your back pain. And that back pain is because of what? Because of the overloading of the facet joint. So facet joint overloading is one of the commonest reason why a spondylolisthesis patient seeks a doctor's attention. But at the same time, another thing happened. What is that? That this foramen becomes narrow, and this spinal canal, spinal canal is between here to here, the spinal canal. So the spinal canal is also narrow. So it is a bony canal stenosis. Bony spinal canal stenosis can be because of the spondylolisthesis. So how a spondylolisthesis patient can clinically present? One is your facet joint pain. Second is your either central canal stenosis or foraminal stenosis, neural foramen through which the nerve root is exiting. So that can also be stenosed. So what will be the presentation of the canal stenosis? So canal stenosis presentation is your claudication. So either there will be lateral canal stenosis. What is lateral canal stenosis? If the foramen is stenosed, so only one nerve root or two nerve root will be compressed or ischemic, and that causes the lateral canal stenosis. That means it will be dermatomal and one leg. Whereas the central canal stenosis, then that produces the bilateral symptoms. So that means a listhesis patient is going to present either a claudication, or if the claudication goes on, what will happen? There will be the neurodeficits. That means patient might be having the burning sensation of the foot. That is one of the very common presentations apart from the claudications. So a listhesis patient, when we should operate. So there are two reasons to determine whether the operation is needed. One is if the patient is having the the neurodeficits, patient is having the burning sensations, patient is having the numbness, patient is having the motor weakness, then operation is must. And second reason why operation is must is if the listhesis is unstable. So what is called? What is called an unstable listhesis? So whenever we see a patient of listhesis, this is again very important for all of us, all pain physicians, that if we see a patient of listhesis, we should immediately order an flexion extension X-ray. That means lateral view. You see, there are three pictures, A, B, C. So the A is ordinary standing position, B is your flexed position, okay, and C is your extended position. So we have to see whether this flexion and extension, the listhesis is changing its grade. If it changes its grade, then this is called an unstable listhesis, and that listhesis should be operated by plate and screw. If the listhesis is stable, then unless there is neurodeficit, these patients need not be operated. You can go for the facet joint injection, you can go for the nerve root injection or epidural. So these all things can be tried. So normally grade 1 operation presents with a stable listhesis. Sometimes grade 2 also presents with stable listhesis. But if it is unstable, grade is not that important. Stability is more important. So if the stability is hampered, then we should refer this patient to the neurosurgeon or spine surgeon for the fixation surgeries. So look at here. So here it is a standing one. Here it is a flexion, and you see here it is a grade 1 listhesis, approximately 25%. Here you see it's a little more than that. So if the grade is changing, then that should be operated. So 1 or 2 is not important. 1, 2, 3, 4, 5, 6 is not important. So more important is whether the listhesis is stable or not. So unstable listhesis means if the grade is changing on flexion and extension lateral view X-ray, so that is important. So remember, whenever you are getting a patient of listhesis, you should order, and again very important is if it is associated with the lysis, is it operation is needed? Again, answer is same. So lysis is also, operation is not mandatory. Operation is needed if there is an unstable listhesis. That means if flexion extension X-rays is changing the grade, whether its listhesis is associated with lysis or not, operation is needed. Okay. So now this is what I was telling, your neo classification of sacroiliitis. So in the spondyloarthropathies or ankylosing spondylitis, sacroiliac joint is one of the commonest joint which is involved, and this grading can be done by the X-ray, plain X-ray. But nowadays it is told that MRI is more sensitive than the X-ray to have the sacroiliitis, to diagnose the sacroiliitis. But another very important point to remember that the sacroiliitis and sacroiliac joint pain do not have the linear relationship. That means sometimes you see the sacroiliitis on the X-ray, but that is not responsible for pain, and vice versa. That means we see the normal looking X-ray or normal looking MRI on the SI joint on the MRI, and still that sacroiliac joint is painful. So to diagnose a pain coming from sacroiliac joint, we should think of diagnostic local anesthetic block, not the X-ray or MRI. Then should we order an X-ray or MRI? Answer is yes. Why? Because these structural changes, that means whether there is any sacroilitis evidence is there on the X-ray or MRI, that is important to classify spondyloarthritis. So the spondyloarthritis diagnosis is difficult. So it is a composite scoring system. So you should be having a lot of other evidences together. One of the very important evidence that carries 3 marks in the diagnosis of the spondyloarthritis, that is your presence of sacroilitis, either by MRI or by X-ray. So that sacroilitis may or may not be painful. But if sacroilitis is there radiologically, that helps us in making the diagnosis of spondyloarthritis. Because spondyloarthritis, sacroilitis is one of the very important features. But remember that sacroilitis is not equal to a painful sacroiliac joint. Whether the sacroiliac joint is painful or not, or whether the pain is coming from SI joint is not or not, to diagnose that, we should go for a diagnostic local anesthetic injection in the sacroiliac joint. And if you are looking about this, how much of this image and the sacroiliac joint pain correlates, it correlates only in around 45% situation. That means in 55% situation, either SI joint is looking normal, still it is the source of the pain, or vice versa. Means sacroilitis is there radiologically, but that is not the source of the pain. Okay, so coming back to the newer classification, this is your grade 1, it's normal looking. Then is your, you can see the grade 2. So you are having the, see the irregular margins, and then, rough erosions. So the, and second is the sclerosis. So the grade 1 is normal, grade 2 means there will be either sclerotic joint, sclerosis means it will be looking more dense, and irregular margin. And third is the joint will be eaten up. So like some insects are eating up these things, or joint space is very narrowed, either of that. Third is this is the third, and fourth is your joint is completely obliterated, fusion. That is your grade 4. So grade 1, this is your mild sclerosis, or maybe looking normal. This is your grade 1 sclerosis, very mild looking sclerosis, or almost looking normal. Suspicion of the sclerosis, I should say. Then is the irregular margin and your sclerosis. Third is very gross, the erosions, and the grossly reduced joint margins. And fourth one is it is completely fused. So this is your 4 grades of sacroilitis. So this is your which grade? This is your grade 4. You can see here it's completely fused. We cannot see anything, any sacroiliac joint here. So now it's CT scan. So there are a few conditions which you are looking for the X-ray. Vacuum phenomenon, then your spondylolisthesis, spondylolysis, and then is your the sacroiliac joint, the sacroilitis. So there are a few things which we diagnose by the X-ray. Then CT scan. CT scan is very important in acute spinal trauma. I'll be discussing more just now regarding the spinal fracture. Then is your bony spinal canal stenosis. That means if there is a listhesis that is causing the spinal canal stenosis, then CT scan is better than MRI. MRI, soft tissue spinal canal stenosis like ligamentum flavum, like your disc, then MRI is better. Then is if there is a degenerative spinal disease, if there is a calcification, and when MRI is contraindicated. Like if there is a metallic implant, a non-compatible metal implant, then we cannot go for the MRI, then you have to go for the CT scan. So there are areas where the CT scan is done, but out of all these things, remember that all of these things can also be diagnosed by the MRI. So we cannot, mostly we cannot go for the both MRI and CT, but for the fracture evaluation, both CT and MRI should be the ideal, because the CT will be telling you the bony outline, and MRI will be telling you the soft tissue outline. Both might be needed in evaluation of the spine fracture. Okay, so here you see this is the CT scan. So vertebral body is like an X-ray, but your structures are much more, it is through the which part? It is the disc. Why? Because it is not as wide as this facet joint. So this is the facet joint. This is your superior articular process. This is your inferior articular process. This is your lamina. This is your spinous process, and this is through the disc part. And you can see the canal, bony canal diameter also by this CT scan. Now this is a kind of the fracture. These sections are through the middle part. So now I'll be discussing a little about the different types of spine fracture before going to the other part. So here we all remember the Dennis classification of spine fracture, and also the Dennis 3-column concept. So whenever you're talking about the spine fracture, you need to remember the 3-column concept. So what is the 3-column? So the spine is divided into 3 columns. One is anterior 2/3 of the vertebral body and anterior 2/3 of the disc. Anterior longitudinal ligament is running here. The anterior annulus. So all these are your anterior column. So what are the components of the anterior column? Anterior column component is anterior longitudinal ligament, anterior 2/3 of the vertebral body. If you are drawing an imaginary line from here, so anterior 2/3 of the vertebral body, anterior 2/3 of the disc, this is your anterior column. Then your middle column. Middle column is posterior 1/3 of the vertebral body, posterior 1/3 of the disc, and posterior longitudinal ligament, which is running like this. This is your middle column. Posterior longitudinal ligament and posterior 1/3 of the vertebral body, posterior 1/3 of the disc. And what is posterior column? Anything posterior to the posterior longitudinal ligament is your posterior column. So what is there? Whole of the spinal canal contains the lamina, the ligamentum flavum is here, the interspinous ligament is here. So all these are posterior column. And remember, the posterior column is most important to keep the stability of the spine. So we told that the pars fracture. So pars is very important for the stability. Same way, ligamentum flavum, the interspinous ligament, the supraspinous ligament, all these are very important structures to keep the stability. And these ligament structures cannot be, can you see the ligaments here? No, we cannot see the ligaments here. You cannot see the ligaments here. So the ligamentum flavum, the interspinous ligament, we can't see here. So that can be identified only by the MRI. So to look at the posterior column integrity, so we need to have an MRI. And how we can identify the base, the bony part? By an CT scan. So ideally, particularly after the major spine trauma, we need to have both CT scan as well as the MRI. CT scan for having a good outline of the the bone, and for the nerves and the soft tissues are best identified by the MRI. But if we cannot have the both, at least MRI. So there are Dennis classification. There are few major classes of the just outline. One is your anterior OH fracture. So what is anterior OH fracture? The anterior column fracture is called anterior OH fracture. So why it is called OHing? So if there is a compression force anteriorly, and sometimes there is no need of any accident. What is only body weight, particularly in the severely osteoporotic bone, it can get compressed. So that is called anterior compression fracture. So anterior compression fracture is by OHing. It is also called the OHing fracture. So this is the most important common, and here the role of the pain physicians. Then second is called the middle column fracture. Middle column fracture is called the bast fracture. That means posterior 1/3 of the vertebral body. This is fracture is called the bast fracture. The bast fracture cannot happen itself. So what is this fracture? This is here, you see the posterior 1/3 is almost intact. So this is a kind of wedging fracture. So wedge fracture is not necessarily like a wedge. So it is basically anterior column fracture. But if there is a bast fracture means posterior column fracture, that can be associated with the anterior column fracture, or that can be associated with the posterior column fracture, or both. So if the posterior column fracture is associated with the anterior column fracture, that is called the stable burst fracture. And if it is associated with the posterior column fracture, this is called unstable burst fracture. So anterior column fracture, middle column fracture, and posterior column fracture. Posterior column fracture again are two broad type. One is called fracture distraction. So along with the fracture, there is a distraction. That means this ligamentous part will be distracted, and particularly this happens in the seat belt injury. So you are having the seat belt. There is a car is having the accident. So you are acutely flexed. So these structures will be separated, and this is called the fracture distraction. And fourth one is your fracture dislocation. So both is the fracture posterior column fracture. Anyway, so these are broad classifications of the different kinds of spine fracture. So this is your clearly the burst fracture. See, the posterior column fracture is the burst fracture, and here also you can see the fracture fragment is coming posteriorly. But to say whether it is a stable or unstable, we need to identify whether the burst fracture can be associated with the neurodeficits or may not be associated with the neurodeficits. But whether it is stable or unstable, that is determined by the MRI, whether the ligamental structures are intact or not. So now another very important aspect is the discography, already discussed by Dr. Devjyoti in the earlier class. So discography, the Dallas classification, grade 0. Then if it is an anterior 1/3 leakage of the nucleus pulposus, this is a grade 1. Middle 1/3, grade 2. Up to the outer 1/3, but without any circumferential spread is your grade 3. If there is a circumferential spread more than 30 degrees, 30 degree means if you are having a point and if you are measuring this angle, so this angle, if the circumferential spread is less than 30 degrees, this is your grade 3. But if it is more than 30 degrees, like here, how to know 30 degrees? So from middle, you draw a point here and point here, and now you draw this, you measure this angle. If this angle is 30 degrees, less than 30 degrees, that is grade 3. If it is more than 30 degrees, that is grade 4. And if the nuclear material is leaked outside, that is your grade 4. So the other 4 types of Dallas classification. CT discography is one of the very important investigations. Mostly earlier when we used to do a lot of discographic procedures, that time after the discography, CT scan should be done. And here you can see this is a normal. Here you can see that this material is, the nuclear material dye is coming up to the outer 1/3, but there is no circumferential spread and no leakage outside. So this is your grade 3 disc degeneration. And here you see there is circumferential spread. So this is your grade 4 in Dallas classification. Now come to the MRI. So in the MRI, we can have a lot of diagnosis. One of them is your internal disc disruption diagnosis. Then is your disc prolapse, spinal canal stenosis, the end plate changes, the tumor, the fracture. So all these things can be diagnosed with the MRI. First, before going into the MRI, we should know about the different kinds of image. T1, there are 4 major kinds of images. T1, T2, STIR, and fourth one not here is your contrast enhanced MRI. Normally, T1 or T2 is given in all. If you are not asking for STIR, your the laboratory or MRI center will not do STIR or not do contrast enhanced. So contrast enhanced and the STIR only when you are ordering it. Otherwise, T1 and T2 will be always given. So it is a black and white picture. It's not a colored picture. So the black and white picture, so we have to understand that it is a gray scale. So some structures looks very bright white, some structures looks very black, and in between in the gray scale, some structures are gray depending on your how much whiteness or how much blackness is there. So we should know which structures looks white in T1, which structures looks white in T2, which structures looks white in STIR, and which structures looks white in the contrast enhanced MRI. So first is your T1. T1, which structures looks white? It is the fat. Any structures, any tissues which is having a very bright, very lot of fat, it will be looking bright white. Like you see here, subcutaneous fat, it is looking very bright white. It is your epidural fat. See, epidural fat is also looking bright white. And which structures will look black? The structures which don't have any fat will look black. So you see, vertebral bodies are not looking that black. Why? Because it has the bone marrow, and in the bone marrow you are having a lot of fat. So it is not as white as this, but still it is not black. It is gray, because it still has some marrow fat. But here, if you are comparing this and this is having more fat. So this can be because of the fat, or it can be because of the water also. I'm coming to that later on. But here you have to remember, T1 only fat looks white. So if it should be fat. And you see here, you see here it is water, no fat, a very little fat. So this is looking black. So which will be looking black? The structures which don't have any fat will look black in T1. Now come to the T2. In T2, what will be looking white? The fat will look white, as well as water will look white. Both will look white. And what will look black? Where there is no fat, or there is no water, that will look white. So now look at here. So here you see the subcutaneous fat looking white because it is fat. Then you see posterior epidural fat is looking white. Then you see that CSF, so spinal cord is ending here. Spinal cord don't have the fat or water. So up to L1 we are having the spinal cord. So up to here, so we are having the the spinal cord, and it is looking black. But after that, it is the chorda equina floating in the CSF. So CSF is looking white. See, disc don't have fat, don't have much water in the elderly. So that is also looking blackish. This is looking grayish because it is having some water, some fat. This is looking white because you see, that means you can understand that this vertebral body, which one? 5, 4, 3, 2, 1. That means L1 vertebral body is having the fatty infiltration. This we can say, because here also it is looking white, here also it is looking white. So most likely this vertebral body has the fatty infiltration. And then come to the STIR. STIR, what looks white? It is only water that looks white. It is also called the fat suppressed image. So fatty things will no longer be looking white like T2. In T2, both fat as well as water will look white. So here you see subcutaneous fat is no longer looking white. You see epidural fat is no longer looking white. So what is looking white? CSF is looking white because of water. And see this T1, which is looking white here, now no longer looking white. So, and vertebral bodies are also looking little black. Why? Because the marrow, bone marrow, fat, and also water, they are also suppressed. So bone marrow, the vertebral body have a lot of venous plexus. It is having a lot of fats. So because they are suppressed, the vertebral bodies are also looking blackish. So only thing is water in the CSF that is looking whitish. So remember, there are a few things in the different kinds of image, T1, T2, STIR. Another is your contrast enhanced. So in the contrast, whatever structures will be taking the contrast. Which contrast? It is the gadolinium, and that is why it is also called the gadolinium enhanced image. So the gadolinium, which structures will be uptaking the gadolinium? Normally, it is the granulation tissues. The fiber structures will be uploading the fresh, recent, the fiber structures. That means if there is an epidural fibrosis, if there is an infection, there will be granulation tissues. So that will be uptaking it, and that will be looking white. So the gadolinium uptake, where it will be more, it will be looking more white. Particularly, if you wish to understand whether there is an infection, chronic infection, particularly where the granulation tissues are there, or if there is an epidural fibrosis after the surgeries, so there we need to order an contrast enhanced MRI. Okay, so now let us come to the. So question is, this is your what, this is what, and this is what. So you see, this is your T1. Why? Because the CSF is looking black. This is T2. Why? Because CSF is looking white. This is STIR. Why? And this is your fatty infiltration. This is an abnormal condition. So the epidural fats, the fatty infiltrations of the epidural space. Here it is there in both T1 and T2. And STIR, this fat has been suppressed. The epidural fats which was there also suppressed, not looking as white like here or here. This fat is suppressed. And the disc, you see, so the disc is here is looking white. Okay, so this is another. This is your T1. So I have given a lot of image. Not all image are looking same. That's why I have given. So this is also here. See, this is your T1. Epidural fat looks white. You can see here. This is T2. Epidural fat as well as the the CSF is looking white, and your disc material also having the water. It is looking white. And this is your STIR, where the water, disc water, nucleus pulposus, and disc here is looking white. So you see, some discs are looking whitey, some disc is looking black. Why? Because the disc when we are younger have lot of water, and if we are growing older, so that is called the aging of the disc. So what is called the aging of the disc? So the disc hydration will be less and less and less. So the spine will not be flexible. So if the disc has a lot of water, the spine will be more flexible. So when we are going older, the disc hydration will be less. So this we can say that this spine, this MRI is most likely a younger than the other one where the disc was looking more black than this one. So how much hydration is there? That also another thing also you have to remember that in the whole day, in the morning we'll be having early morning. If you are doing an MRI, disc will be looking whitish. If you're looking MRI in the evening, the MRI will be white, because when they are doing the lying down, then how much water will be there depends on the two factors: interdiscal pressure versus the hydrostatic pressure, osmotic pressure. So osmotic pressure will be trying to absorb the water. Interdiscal pressure will be trying to force the water out. So in the whole night when you're lying down, interdiscal pressure is very minimal. So it will be imbibing the water. So morning disc will be having more hydration than in the evening. Because in the evening when you are standing, walking, so that time interdiscal pressure is more. So disc water will be coming out. So elderly populations and in the the evening, the disc will be having the less hydration. So the same image. So this is another very important image. I'll be discussing it more often. So you can see later here. This is T1. Why? Because the CSF is looking white and the epidural fat is looking. CSF is looking black and epidural fat is looking white. And here you see this is looking black, whereas this is looking white. That means this is your water, not fat, and this is called your modic changes. I'll be coming to this later on. So now the MRI, there are three types of sections are there. One is called the sagittal section. Sorry, this is sagittal sections. We are taking it from the midline. Then you are having the transverse sections, and then you are having the coronal plane. So the coronal plane is like this. So all these three are very important. So this is your, what is this one? This is your sagittal. This is your coronal, and this is your transverse. So this is again very important that when you are having a this is your sagittal. So this sagittal plane has been taken from exactly in the middle or little bit side of the middle or in the foramen. That is also very important. Otherwise you will not be able to understand what exactly is the structures. So we need to know that this sagittal section has been taken from which part and vice versa. When you are having a the transverse sections, we need to understand that this transverse section has been taken from which level. That is also very important. So first you see what we see in the sagittal section. This sagittal section has been taken from the midline, exactly in the middle. And if it's taken exactly in the middle, you can see the CSF. You can see the spinal cord is ending at this level. This is our 1, 2, 3, 4, 5. This is 1. So spinal cord is ending at here, and then the CSF is starting, and the cortical fibers are here. And you can see the vertebral body. You can see the epidural fat here, looking white. This is your T1 or T2. This is your T2 because CSF is looking white. You can see the vertebral end plate. We can see the annulus. This is annulus. This is annulus. You can see a very mild fissure in the disc. So this is common in 30s also. So this starts in 30s. early, this is the signs of the degeneration, not degeneration, sorry, dehydration. This is the earliest sign. So now we see, you compare with this one, this was from the midline, and the next one, this is taken from the just, this is the foramen, and just inside the foramen. And here you can see this is your traversing nerve. So here you can see this is your traversing nerve. Traversing nerve means the nerve which is coming out of the spinal cord, still within the spine, the spinal canal, and the next level will be going outside. Okay, just let me talk about this slide first, and then I'll be coming back to the other side, other slide. So you see here, suppose this is your L5S1 foramen. So this L5S1 foramen, this nerve root is, what is this nerve root? Is your L5. So this is your L4, L5 foramen. What is this nerve root? Is L4. That means L4 nerve root is exiting through the L4-5 foramen, and it occupies the upper part of the foramen. So where is the foramen? So this is one pedicle, this is another pedicle. So the foramen is from here to here, and nerve root just comes just below the pedicle. Just below the pedicle. That means upper part of the foramen, we have the nerve root. So the exiting nerve root is at the upper part of the foramen. Foramen is from here to here is the foramen, and exiting nerve root is the upper part. So L4 nerve root is exiting through the L4-5 foramen. Okay, and at this foraminal level or at this disc level, which nerve root is traversing? It is the L5 nerve root. So the L5 nerve root is here traversing. It is coming close to the foramen, and then it will be exiting out. So the L4 nerve root is exiting through the L4-5 foramen, and it is traversing at the level of L3-4. That means above level it is traversing, and below level it is exiting. Okay, so remember these things. Another very important things to remember, suppose this disc is prolapsed, if that is L4-5. So normally if this disc is prolapsed, L4 nerve root is normally escaped, unless the disc prolapses to lateral or going up. If it is the commonest one here, then it is L5 nerve root will be involved. That means L4-5 prolapse more commonly affect the L5 nerve root, which is traversing, which is not exiting. So at the level of the L4-5, L5 nerve root, which is traversing, is involved more, not the exiting. When the exiting nerve root will be involved? When the disc prolapse is for lateral, that means when the disc prolapse is here, or when the disc prolapse is upward migrated, then the exiting nerve root might be involved. Okay, I'll be discussing this point later on again. Let me come back to this slide first. Okay, so here, this is the structures midline. Then if you're taking the structures from here, now you can see this is your traversing nerve root. This black line, which was not there in the earlier, in the midline. So here is this nerve root is your, this black dot is your traversing nerve root. So if you are going to that nerve root, so this nerve root is basically your the traversing nerve. This is your traversing nerve. This is your traversing nerve. This is your traversing nerve. So if your section is taken, at the level of which level it was midline. This was at the mouth of the foramen, or this is also called the lateral recess. So if this section is taken from the lateral recess, which is the mouth of the, this is the foramen, so then you can see the traversing nerve root. So this black line is your traversing nerve root. Then if you are taking this section through the foramen, so this is your foramen, so this is your the superior articular process, this is the inferior articular process. So here you can see the foramen. So the foramen is from, this is one pedicle, this is another pedicle. So foramen is from here to here, whole is your foramen. So the foramen, anterior boundary, what is the foramen? Anterior boundary, upper part is by the vertebral body, lower part is by the disc annulus. Posterior boundary of the foramen, upper part by the superior articular process, lower part by the inferior articular process. So above foramen boundary, so always remember, neural foraminal boundary is very, very important. What is the anteriorly, what is the posteriorly, what is the superiorly, what is the inferiorly? Superior inferior is very easy. One pedicle to another pedicle is your the superior and the inferior boundary. And this is your the contents. What are the contents? Another thing, remember that this upper part of the neural foramen is the most wide. The lower part of the foramen is not that wide, and that's why you see the upper part is broad. Why this is white? This is because of the foraminal fat. There are lots of fatty tissues are there. Notice this black dot. This black dot is your exiting nerve. So when you are coming into the foramen, then you can see the exiting nerve. This is the exiting nerve. And to see the traversing nerve root, you have to go back. This is your traversing nerve. This is within the spinal canal. But when you are coming at the level of the foramen, then you can see the exit. This black dot is your exiting nerve. And there will be small dots of the vessels. Normally, the vessel is just anterior to the exiting nerve root. There are few other small vessels and lots of ligaments are there, which is holding the nerve root in position. Then to the other side. So always remember, this side is your right side, this side is your left side. So this side is your on the other side. You can see the one pedicle to another pedicle is your foramina. We are having the nerve root there and the fat tissues are there. And now we are looking at the transverse sections. And if you are taking the transverse sections, we need to know from where this transverse section has been taken. That means we should be having a sagittal sections which will be drawn and to understand. So this sagittal section is taken through the L5S1 disc. And anterior part is your, this is the vertebral body. No? That's not the disc. You see how it is? The vertebral body. So posterior part here is your disc. This is your annulus. And this is your, this black dot is your traversing nerve. And exiting nerve will be here outside. Here, this is taken from, so this is the transverse section which is taken from the L4-5 disc, middle of the disc. So if you're taking the middle of the disc, this is very, very important that you should be having a very good annulus. You see this black rim is your annulus. Why this is black, looking black? This is titulated image because annulus is having the fibrocartilaginous structures. It is neither have the fat nor have the water, so it looks black. Whereas you see the disc have water, that's why it is looking little bit white. Not as white as this, but still it is looking little bit white because it is having water. And this is CSF. This is your, the superior articular process. This is inferior articular process. This is your ligamentum flavum here. And this is your traversing nerve. And this is your foramen, neural foramen. This white area is your neural fat. And this is your exiting nerve root, which is already divided. So sometimes you see the exiting nerve root is a compact. Sometimes you see it's a division. So this is the exiting depending on exactly from where the section has been taken. So the exiting nerve root will be seen either here or here in dividing. Traversing nerve root will be seen just inside into the foramen. So this is your traversing nerve root. Now see, this is a normal anatomy. You see, so when you are looking for the traversing, the transverse section is very important. So each transverse section we must be knowing from where this section has been taken, and there will be point 1, 2, 3, 4, and here also will be written. So to understand this, we have to look for this from where the section has been taken. So see, these are the this and this. What is the difference? This is taken from the disc level, so you can see the annulus very nicely, and this is taken from the vertebral body or cartilaginous bed. That's why you cannot see the annulus here. So here also it is taken from the disc level. You can see, you can match also from this line also. You can see, and at each level, what are the things we are looking? You see, we are looking. Suppose this is annulus, very nice annulus. So this disc is very healthy. You can see this is your superior articular process, inferior articular process, and this white thing is your synovial fluid. You see, this is synovial fluid in the facet joint. So this is your spinal canal. This black area is your ligamentum flavum. This is your the foramen, neural foramen. This black dot is your traversing nerve root, and this black dot is your exiting nerve root. So this white area is the foramen. Okay. So here also you can see the things. Here you can see this. Just immediately above that section, you can see the exiting nerve root here, little bit in the foramen. Here it is outside the foramen. So here also you see the exiting nerve root. This is the traversing nerve root. Okay. Here exiting nerve root has already been divided. Here also this is the traversing nerve root. Exiting nerve root is not nicely seen, maybe because of the divisions. So by this way, you should be understanding. See, this is the synovial fluid. This white area is the synovial fluid. This is your inferior articular process. This is your superior articular process. This is your superior articular process. This is synovial fluid to the facet joint. This is your inferior articular process. This is your spinous process. This is your annulus, the black rim like a tire. So this is your annulus. This section is taken from the, you cannot see the annulus. So this section has been taken from the end plate. So you should be understanding from where this is taken, right? So this is your normal MRI. So here also, I'm just skipping through this. So you see here, this is your taken from the disc level, and see disc is degenerated. Why? Because we cannot see the annulus nicely. So nuclear material is coming towards the periphery. This is your traversing nerve root. This is your exiting nerve root. Another thing you remember, exiting nerve root is because it is a divided. Exiting nerve root is broader than the traversing nerve root is much more compact. So this is your the traversing exiting nerve root. This is the traversing nerve root. Here also this is the traversing nerve root. This is the exiting nerve root. Okay, this is pathological. I'm not going to the pathological thing. Already I discussed this one. This is another. So if this disc is prolapsed, so if it is an L4-5, normally it is the L5 nerve root which is getting compressed. L4 can be getting compressed if the disc material is upward migrated or if it is a far lateral going towards here. Okay, so now this image is important. You just look for this image. These are the different types of the prolapse disc. You see, it can be central, posterocentral prolapse, exactly into the central area. And see here, it can be presented only with the canal stenosis symptoms, but bilateral nerve roots can also be getting involved. Then is your this paracentral, posterocentral. Here it is the traversing nerve root. This is your foraminal. So this is here your exiting nerve root will be involved. This will be the traversing nerve root will be involved. Here it will be the exiting nerve root will be involved. Here it is the extraforaminal. And again the exiting nerve root will be involved. And this is the most common type of the disc prolapse. So normally the traversing nerve root is more commonly involved. So again, so this is the posterior, fully posterior central. This is your the posterolateral. This is your foraminal, and this is your extraforaminal. So here it will be either canal stenosis or bilateral. This is your traversing nerve root. Bilateral traversing nerve root will be involved. Here this will be your only one-sided traversing nerve root will be involved. Here it will be the exiting nerve root will be involved, and here extraforaminal will be your only the exiting nerve root will be involved. But these two varieties are less common. These two varieties, B, C, and D, are less common. B is the commonest one. So here, a few of the other examples. Here you can see that this disc is looking very wide. This is not that wide. And here you can see there is some fragments of the the nucleus pulposus is coming. So this normally presents with the internal disc displacement. I'll be coming to that later on. Here you can see what kind of prolapse is this. This is your foraminal prolapse. So normally this will be presenting with the exiting nerve root compression. So you can see the same picture here. It is the exiting nerve root. So you can see this is the exiting nerve root. So this exiting nerve root is getting compressed by the prolapse disc. So here, what kind of prolapse is this? This is your paracentral prolapse. And here it is a traversing nerve root will be getting involved. And it's a big prolapse, very big prolapse. So if it is an L5S1 disc, which nerve root will be involved? It is the S1. So, and on the which side? Right side or left side? It is the left side. So if I am asking this question, that describe that what kind of clinical symptoms are expected from this picture if it is at the level of the L5S1. So the patient will be having pain and the paresthesia of the lateral border of the foot, sole of the foot, and toe walking will be difficult. The plantar flexion of the great toe will be difficult. Why? Because here the most likely the S1 nerve root will be involved. So here again the traversing nerve root will be involved. Here is the neural foramen. So it is the superior articular process, inferior articular process. Here is the foramen. So it is the traversing nerve root will be getting involved. Here another, I told you this is the commonest one. So here also this is the traversing nerve root will be getting involved. So here this is a downward migrated disc. You see this material is coming downwards, and you can see at this section this is again L5S1. So this is the disc material. And how will be the clinical presentations? Here will be right-sided. So this is the right side. Right-sided S1, radicular pain and radiculopathy will be the clinical presentations. Why it is important? Because MRI might be asymptomatic in around 50% situation. So unless this MRI is matching with the clinical feature, it don't have any importance. Okay, here it's a very huge prolapse here. Again similar, and here you can see the traversing nerve root is completely obliterated. So this is your supraarticular process, infraarticular process. So this is again the traversing nerve root will be completely obliterated. Here also you see this is the traversing nerve root. This is the commonest type of prolapse. So again another example. Here the disc is having very good hydration. So this is the case where the ozone nucleolysis is going to help, because hydration, if it is there, the ozone nucleolysis helps. This is the type of the prolapse where so this is not a prolapse disc. This is called radiologically it is called annular tear. You see this white? You see the outer rim, that means annulus, is getting narrowed. So nuclear material is leaking peripherally. And here in the annulus, in this black area, there is a white area. I normally talk about the battlefield. There is inflammatory edema. So nuclear material was coming towards the periphery, the vascularity going in. So there will be fighting between the the nuclear material and the body's immune system. And what will happen? There will be inflammatory areas. And this is called the internal disc disruption. So this will be how it will look on the transverse, and this is the sagittal. You can see this is one, and this will be within the layers of the annulus. Normally this presents, this is also radiologically called the annular tear, and normally they present with not with the radicular pain, they present with the back pain. They present with the back pain with the diffuse, the radiation towards the referred pain towards the buttock and the back of the thigh. So this will be the clinical presentations, and this pain will be aggravated on sitting. So this is your modic changes. So modic, this is your modic type 1, type 2, type 3. So let us discuss what are the different types. So type 1, what happens? Here, this is your T1 because CSF is looking white. So here, T1 is looking black, T2 is looking white because this CSF is looking white. That means here there is marrow edema. This is the vertebral body. So vertebral body marrow edema is there. And remember, the modic type 1 changes are very commonly presenting with the back pain. In around, if there is a type 1 changes are there, so in around 2/3 of these patients present with back pain, and low-grade infection has been linked. There is some anaerobic infection, low-grade infection, which probably it's not very much sure. These are the different hypotheses. So this hypothesis is very popular, that there is a low-grade infection which causes the marrow edema, and that causes the diffuse back pain, exactly like that of the discogenic back pain. So clinically, it is very difficult to distinguish between the discogenic back pain and the changes because of the modic type 1. Then, if you are not treating, what will happen? Gradually, over the period of time, this will be converted into the modic type 2. That means these inflammatory areas gradually will be replaced by the fatty tissues. So, if it is replaced by fatty tissues, then T1 also look white, T2 also look white. That means this is your fatty infiltration of the end plate. And still later, it will be replaced by the sclerosis, fibrous tissues. So this sclerosis looking black both in T1 as well as T2. So this is called modic type 3 changes. This is modic type, this is modic type 2 changes, and this is modic type 1 changes. So mostly modic type 1 changes causes pain. So now this is again 1, and here you see here the end plate changes is there. In T2 it is looking white, in T1 it is looking black. So this is your modic type 1, and it can cause pain. So there are this is again another modic changes. You see this is your both this of this taken from the T2 weighted image. This is your T1 weighted image. So this is again modic type 1. So this end plate is looking white. Here this end plate is looking black in the T1. This is your spinal canal stenosis. This is your ligamentum flavum. So this is the area where the ligamentum flavum is there. So this is the ligamentum flavum. You can see the spinal canal is narrow. Mostly The spinal canal stenosis is contributed both by anteriorly by the disc and posteriorly by the ligamentum flavum. This is a synovial cyst. This is not very uncommon. Many times you see this kind of thing. This is on the right side. This is on the left side. This is on the most likely the L4-5. This is most likely L5S1. You can see this is the synovial fluid, superior articular process, inferior articular process, and you can see this is the synovial cyst protruding from the the facet joint, and this can cause the compression of the traversing nerve root. So here also you can see. So this patient should present as a L5 radicular pain. This patient should present as the S1 radicular pain. So this is your synovial fluid, and this is your the. So these are the few other changes, small notes. I'm just this is your the annular tear. So I'm just quickly going through that. But today I'm not going further. So now let me. Okay, so you can unmute and ask me questions.
Sir, may I ask a question?
Yes, I told you other day. You are
sir.
You always know that the first person who will be asking question is you.
Sir, thanks for the compliment, sir. Sir, you told
just a minute.
Yeah, sure.